Hello and welcome to the Secours Neuroscience Community Education Program. We are very happy to be with you tonight. This is our third series on neuroscience topics, and tonight we're very excited that we're going to be talking to you about Alzheimer's and dementia. We're hoping that we're going to bring you lots of resources and education so that we all can share in this community awareness. The number here for you to call into our panel is 804-915-5202, and we will be taking calls between 6:30 and 6:45. So let's talk about, this is November, and during the month of November in neuroscience, we have two things that we celebrate, and tonight I'm wearing purple, and both of them actually celebrate with purple. One was epilepsy, and we had the show last week on that. And this month also, we also celebrate Alzheimer's, and that's what we're here to talk to you tonight. I have three guests who are joining me, and they all are experts in the field and certainly will be able to help us with all of the resources as we go along in talking about Alzheimer's and dementia and being able to give that education that you so need. Our first guest for tonight is Dr. Salmaan Khawaja. He's a graduate of Virginia Military Institute, and he received a Master's of Arts in Educational Specialist degree from James Madison University. He then went on to complete his doctorate in a unique combined program in clinical and school psychology at JMU. Dr. Khawaja then completed his internship at Eastern Virginia Medical School and did a residency fellowship in clinical neuropsychology as well at Virginia Inc. and the University of Virginia and Virginia Commonwealth University. So we are very happy to have Dr. Khawaja. He is our specialist as a neuropsychologist, and he is with Secours Neurological Clinic for us, and we're happy to have you here.
Thank you for having me.
Thanks. Our next guest is Donna, and Donna Spainhour is a clinical nurse specialist, and she specializes in geriatrics. She is the coordinator of St. Mary's Hospital Elder Program, and we're going to hear a lot about that from Donna. As I said, you will hear that she is a geriatrics specialist and she is certified. So she's going to tell us all about that tonight and how that works in the field of Alzheimer's and dementia. Thanks, Donna, for being here.
Thanks for having me, Pat.
And our last guest is Sherry Peterson. She's the executive director for the Alzheimer's organization here in Greater Richmond. And Sherry has over 15 years with the association, and she has done a lot with the organization, and we are very proud to partner with the Alzheimer's organization with Secours. And we're going to hear a lot about their materials and resources, because one of the things we want people to understand tonight is that there is hope. And that one thing we want to help is not only that patient, but we also want to be able to provide information for the caregivers. So rest assured, that is what we will do on this panel tonight. So I always like to start out talking about facts or figures and what's going on or things that could be misled. And so I wanted to start off with something that I think the community often does, and I myself am included, and that we always talk about dementia and Alzheimer's as if they're the same thing. And I don't think that's true. Is that correct, Dr. Khawaja?
That's correct.
So can you help us to understand what dementia really is?
Sure, I'll try my best. So dementia is a term that we use to describe changes in memory and at least one other cognitive function, like attention, concentration, and focus, problem solving, judgment, and decision making, communication, language skills, and things like that. And those changes are not normal for age, education, gender, ethnicity, the medications that someone is taking, or other medical issues. So whenever someone is exhibiting those sorts of problems, we use the term we use the term dementia to explain that particular change. Alzheimer's disease falls under the category of dementia. It is a type of dementia, but there are many different types of dementia.
Okay. So that's one point that I think everybody needs to grasp tonight, is to understand that Alzheimer's actually is a category of dementia. And Dr. Khawaja was really elegant in letting us know that there are certain functions that we're looking at. We talked about memory, attention, and that this is something that usually we see progression over. So I think an important thing here is important to have some type of baseline evaluation, I would say, with your physician, and important for us to have a good history in reference to doing that. So let's talk about, I'm going to bring in some of our other speakers, and Donna, I'm going to ask you a little bit first. Dr. Khawaja talked a little bit about dementia and memory, and I know there's something special at St. Mary's that I wanted you to talk about in reference to what we've done with patients and elderly patients specifically. So if you want to talk about that program.
Sure. It's called the HELP program, or the Hospital Elder Life program. And it's a program out of Yale University that was started in the 1990s by a Dr. Sharon Inouye, who was very passionate about the older adult. And she recognized this confusion, this acute confusion we call delirium. Mm-hmm. So she developed this HELP program where we train volunteers to do targeted interventions to help the patient at the bedside. And those are things like orienting the patient to where they are and their surroundings. Also helping them at mealtime, because we find sometimes food comes out, and if they do have memory loss, it's hard for them to get to the food or know what they have there. So our volunteers assist them at mealtimes to get their food and hydration, their fluids. We also work with our physical therapists very closely. So for those patients that can ambulate, we do actually ambulate those patients, and we particularly want to mobilize all these patients, get them out of the bed, get them in the chairs to help with that mobility and to preserve that function that they have. We also provide therapeutic activities for them. So we'll do some word and number puzzles with them. We also will read to the patients, again, to stimulate their cognitive function and to spend time talking with them. I think one of the big things that we see is our older adults love to reminisce, and it's very, very therapeutic for their recovery and their time in the hospital. And the volunteers have that opportunity to actually take the time to sit with the patients at the bedside, to listen to their story, their personal story, which is so very important for them to share with others. So our volunteers, we have some retired nurses and teachers. We also have a lot of young students that are very, very interested in helping the older adults. So we have a lot of students that are coming to do the HELP program, and it's a wonderful interaction between our older patients and our younger folks. So it's been very, very rewarding.
Great. Thanks, Donna. You brought up another D word that I'm going to come back to Dr. Khawaja about and talk about delirium. But I want to bring Sherry in because I know that the Alzheimer's Association organization does a lot. And they I always like to say, they really meet people where they are. So whether if you have dementia or Alzheimer's or another category of dementia or delirium, you're there to help. So I wanted you to talk a little bit about the Alzheimer's organization, because the greater Richmond area does a lot for the community. And so I want to make sure that people understand before they get off this show tonight where they can get in touch with you, how the resources, and specifically that hotline, I think is very important.
Well, the Alzheimer's Association nationally is the largest private funder of Alzheimer's research and also an advocate for federal dollars for research and services to provide for people with the disease and their caregivers. Locally, the chapter provides, as you mentioned, a 24/7 helpline, toll-free number, and anytime, day or night, that they call, they will actually get, and people are very surprised about this, to talk to a real person. They don't just leave a message. They will get to talk to somebody. And what happens is when we're in the office, we take it, and at weekends, holidays, at night, it goes to our national office, and then when we come in the morning, we have an email saying that somebody had contacted us, and then we follow up with them. So that is available, and I can't tell you the number of times that we will get emails saying that somebody called at 11 o'clock at night or at 2 o'clock in the morning, because that's when caregivers have a chance sometimes. That's the only time. Or when they're so frustrated that they just need somebody to talk to. We also have support groups. We do a lot of education, both for family caregivers, for people with the disease, particularly in the earlier stages of the disease, and as well as for professionals. We do care consultations where families could come in, sit down with somebody, and really kind of get an idea of what they may be facing as the disease progresses, to help them so that they don't have crisis situations. You know, I say all the time that we can't make being a caregiver easy, but we may be able to avert some crises and make it a little less stressful by sharing information with them and educating them. And then we also have some safety programs, because we know that about 70% of people with Alzheimer's or any form of dementia will wander at some point or another. So those are services that are offered, most of them free of charge. For the safety programs and a few of those things there, but for the helpline support groups, most of our educational programs, there's absolutely no charge.
Great. And we're going to get that number too so people can know. Again, callers, you can call in at 804-915-5202, and we will take those calls between 6:30 and 6:45. Dr. Khawaja, I wanted to talk a little bit about, because this is where my little science comes out. How is dementia caused? Or how do you get that? Is that something you catch? Is it a normal process of aging? Does everybody get it? Or what can we do to figure out the causes?
Well, we know very little about what causes dementia, but we do know that these types of changes involve damage to brain cells. And what happens is, as the brain cells become damaged, they're not able to communicate with one another very, very well. And as that happens, there are various areas of the brain that are responsible for our thinking, for our memory, for our attention, our concentration and focus, and we start to see very subtle changes or slow changes in those particular domains. The difference between dementia and normal aging is really, really difficult to determine, especially at the early stages, and that is where testing is such an important part of making this diagnosis. Because the differences between normal aging and dementia are almost impossible to see. Either the patient can't see it or the family members won't see it, and let's be honest, all of us, as we get older, our memories change. Meaning nobody in this room, no offense, including myself, has memory or attention as good as it was when we were 17 or 18 or 19 years old. This just happens to change and slowly decline over time. And a lot of that can be very, very normal. The question becomes, when does that normal change transition into early signs of a dementia-type disease process? And the best way to identify that is to come in and see somebody like me and have an evaluation, because these types of evaluations can actually determine the difference between normal aging and memory loss and early signs of dementia.
Okay. Now, Donna talked about the word delirium. Does that play into this at all? Or
Absolutely. I know patients who have dementia or Alzheimer's are more predisposed to having delirium. So that's a key. It's a risk factor for them. So we try to look at that and then see what we can do to prevent it by getting them the HELP program and getting that stimulation, making sure that they're getting mobilized and getting them up. We find that getting them near windows so that they have light during the day is so important. So it's very simple things that we make sure that are happening so that it prevents further decline.
Okay. And Sherry, I think you guys just had a conference on Monday.
Yes, we
big
did.
Conference,
It's a
and
big
it was on.
Well, we had a doctor from here at MCV, Dr. Adam Rosenblatt, talked about Alzheimer's, what is it, and he also talked about the different types of dementia. We had the vice president of our National Association, who Vice President for Medical and Scientific Affairs, who talked about the research past, present, and where we're headed. And fortunately, there is quite a bit of research going on, and there's constantly adding new research to that, because I think people are beginning to realize that even though many people age normally and don't have any signs of dementia, age is your biggest risk factor. And because our population is aging, our numbers are just exceeding. We know right now there are about 5 million Americans with Alzheimer's disease. And that number, if we don't find a cause, cure, treatment, by the middle of the century is going to more than double. And so fortunately there has been, I think people are beginning to take notice. Death rates, Alzheimer's is the 6th leading cause of death. Death rates from Alzheimer's continue to grow while other diseases, which we have put some very significant dollars into the research for, death rates from those, whether it's breast cancer, HIV, AIDS, stroke, other cancers, our heart disease, are declining while ours are increasing, so that the research is obviously very important. And the other thing that we did in the conference was we had people talk both to professional caregivers and family caregivers about ways that they can communicate, ways that they can, as Donna was mentioning, there's certain things people, we call it sundowning, at night sometimes have problems. So teaching them some tricks that may be able to avoid some of those kind of things.
Okay. I want to also go talk about dementia and parts of the brain, and it just kind of dawned on me too, you know, while we talk about aging, can you say, or would you say if somebody has a stroke, is that considered, and they have some cognitive deficits, some memory loss, is that a type of dementia?
Well, the key thing to understand there is that when someone has a stroke, it can often cause changes in thinking and memory and attention and focus and problem solving, especially speech and language. We see a lot with our stroke patients.
Okay.
The trend is when someone has a stroke and they do not develop a dementia because of that stroke or exacerbated by that stroke, over time those symptoms tend to get better. And that's one of the key things that we look at when I'm evaluating someone either in the hospital bedside or if they're coming into our clinic to see me, is to look at that trend and to talk to family about, are things getting better? Are things staying stable, or are things getting worse over time? Strokes can sometimes lead into a dementia type process. And so what you'll see with a patient who's had a stroke who develops dementia is they improve a little bit over time, and then that trend of decline starts to happen. And testing can be a very good way of determining the difference between those two things.
So talk about some of the tests that you do, because I know people want to know particularly what happens and how will I know, and then we'll go into some of the signs and symptoms of that.
Sure. The testing that we do involves a lot of paper and pencil types of tests and computer-based testing. There are not a lot of needles, or no one's getting poked or prodded or things like that. And a typical evaluation takes about 3 to 4 hours in our office, and it's usually involved in a 2-visit process. Okay. The first visit, I'll meet with the patient and hopefully the family members or someone who knows their significant other to talk about what exactly is going on and to get a better sense as to what sort of testing is necessary. And after that is done, we'll bring the patient back and actually do some cognitive testing where we're measuring very objectively that person's attention, concentration, focus, and memory. These tests are really hard to fake. And after the patient leaves the office, that's where my work really begins, because at that point we can statistically adjust for what's normal for this particular person, with this level of intelligence, with this level of education, of this gender or this ethnicity, if they're taking these medications or that medications, and what their medical history is. And we can sort all of that out to determine, is there something else going on that's causing that memory loss or those other problems? Is it normal aging or not? Is it depression or anxiety? And we can talk about that, I'm sure, in a few minutes, about how that exacerbates or makes things worse. Is it delirium or not? And we can really piece apart these types of issues very early on. And one of my key points to remember for the audience is early detection is the most important thing. Most of my patients, unfortunately, wait too long before they come into my office. And that's one of the biggest concerns that I have.
And I'll say that to the community. I think that's true of a lot of neuroscience diagnoses or issues. Don't wait for a stroke. You don't wait for when you see those differences from a baseline. So I always say, know your body and don't be afraid to tell somebody, because there is hope out here. So Dr. Khawaja talked about a lot of things that I wanted to bring you all into, particularly you, Donna, somebody coming in the hospital. Let's say they are labeled, or somebody says they have a dementia. What are some of the things that you look at? You brought up meds, and we'll talk about depression, but what are some things that you do right away just to make sure that they're safe? You talked about the stories and memory, and so that was kind of aha moment to me. I might come back to you for that. Sure. And with the memory, I mean, so it's a memory loss, but is it new memory, old memory, or let's talk about memory for a little bit.
And that's one of the challenges. If somebody's coming into the emergency room and they might be having chest pain, or maybe they have a high fever, they have an infection. So at that point, of course, we're stabilizing them. But in the meantime, while we're interacting with the patient, is trying to get a cognitive baseline with these patients. It's so very important. And if they have a family member or a caregiver that is with them, it's wonderful because they can give us some idea of what their baseline is. But if a patient comes in from a facility and there are no family members, we really are kind of lost as to knowing where the changes are. And I look at our records from the emergency room, and a lot of times we have altered mental status, but we really don't know what's going on. Is it dementia? Is it delirium? It's very hard to get the history on the patients. And so it makes it very challenging to take care of them. But we find, I know if a patient comes in with an infection and they're treated on antibiotics, and in a day or two we see them clear, it's amazing that cognitive function, how much better it gets, and we see what their baseline was. Again, very important to get that baseline, and a challenge for sure.
Mm-hmm. Okay. Now, Dr. Khawaja, let's talk about treatments, and then we'll talk about with Sherry some of the signs and some of your materials you have, which are really good. So if somebody comes in and you notice in their testing that they are having series of memory loss, et cetera, what are some things that can be done?
The most important thing from our standpoint is to understand where the problems are coming from.
Okay.
Because usually with a dementia type issue, there are other issues that are going on as well. Depression being one of the most common, but oftentimes there are other medical issues going on. Our patients sometimes have had brain tumors, they may have epilepsy, they may have had strokes or TIAs or other medical factors. And if we can delineate all the different things that are going on and kind of itemize them and say, this is the level of dementia, here's where we are. Here's what the stroke that exacerbated that. Here's where depression plays into that. We can develop a treatment plan that addresses all of those things. There are a number of medications, 3 very common medications out there that are given to patients who have dementia that have shown some efficacy, especially when it's caught very early, in slowing down the progression of this disease process. So if it's caught early, I have a number of patients that I've been following now for 4 or 5 years, if not more, and we got them started on medication early, and we're seeing very, very little decline over time. So medications are usually one of the most common types of treatments. If there's depression, we're going to address that. I'm sure we'll talk about some other things as well, but I always encourage my patients as well to be as physically, as mentally, and as socially active as possible. So it's not just about a pill, it's about lifestyle. It's about family support. Dementia is not a disease that involves one individual. There is almost always a family or a community aspect to that. And as much support as we can get into place, and as independent as we can get that patient to feel, all of those things are really, really important.
So I'm going to go right to you, Sherry, because I think that's where you all do a phenomenal job of understanding that quality is very important in the community. And I always say with Alzheimer's dementia, you got to pack your patients as well. So what are some of the strategies or things that can be done out in the community for people to feel like they have hope and to understand and to keep them safe? Those are the things I think of, having patience and making sure that they're safe.
And maintaining your sense of humor. That's one of the
Absolutely.
things we tell caregivers.
Okay.
It's very, very important to do. And I think for the people with the disease, particularly those that if we have contact with them early enough in the disease process, because we realize it is a progressive disease. So even though people may level off for a while, if it's Alzheimer's, there's going to be some progression. But certainly, as I mentioned before, that education is so important because we want to them to have some understanding about what is the usual progression. I won't say normal because every person is different in the way they go through the disease process. But what are some of the things that families should be aware of? And you were right before when you said the family. I had a caregiver one time say to me, when my husband was diagnosed, the whole family was diagnosed. And particularly as the disease progresses, it's difficult for family members, young kids who go in and grandma doesn't know who they are anymore. To try to explain that to them. And so we've done some programs with kids to explain that to them, to try to help them understand, to answer their questions. In regard to safety, there's a medical alert safe return program that people can register with. We've done a lot of training with local law enforcement and first responders so that they understand how to approach somebody if a family member calls and said, my loved one has disappeared, and so that the police, when they do find them, know how to interact with them. There's a comfort zone, which is a web-based program. So if somebody does wander out of what they've set up as their comfort zone, they would the family member would get a notice on their cell phone or on their computer and know that their loved one has gone out of the area that they had designated as that comfort zone. So there are programs out there, and we certainly encourage people. Again, I mentioned that about 70% of people with Alzheimer's will wander at some time. And maybe they've been walking around the block every day for the last 2 years, and all of a sudden one day they make a wrong turn and they don't know where they are. Unfortunately, that also happens when they're driving. That's one of the issues that I'm sure the doctor also deals with is how do you tell your loved one that they shouldn't be driving anymore, and when is the right time for that? And we have some information on driving that we can give to people, and certainly encourage them that that's something that they need to be aware of.
So how do you prepare for that? I mean, because that's, I'm like, oh my
Sorry,
gosh, that's something. No, I think, but that's real. I mean,
it is.
And how will I know when we're at that stage? And how do you bring the person in if, it's slowly progressing or you're not there? How do you have that conversation?
I would say that one of the most difficult aspects of what it is that I do relates to driving and conveying that information of, hey, I'm sorry, but I'm not going to let you drive anymore. That is a very, very difficult and a very challenging decision to make, especially we have GPS now. And there are methods, of tracking where a car is and things like that. With the neuropsychological testing that we can do, we actually measure a person's reaction time, their response time, their problem solving, their judgment, their attention and focus, and we can measure this in millionths of the second to determine whether or not that person, they may know what the right thing to do is. The classic example I talk to patients about is if some children are playing in a yard and they're playing with a ball and the ball rolls out into the street and the child runs out into the street after the ball, does that person know what to do or not? In early stages of dementia, well, of course they know what they're supposed to do. They're going to slam on the brakes. The question is, can their brain communicate that to their foot? I need you to come off the gas and slam on the brakes fast enough, and we can actually measure some of those things. And a lot of times I will send a patient for an occupational therapy driving safety test to determine whether or not that person is capable of driving safely or not. But that is a very, very difficult conversation to have. One of the, a lot of my patients will say, that's fine, doc, I've got dementia, I understand that, but don't take away my driving. And that's the most difficult thing, and they'll come in and talk and really, really be upset. Driving is quite a privilege because it represents so much freedom. And when we take that away, now all of a sudden, they are becoming reliant on anybody else, public transportation, family, if they just want to run over to the grocery store, now they can't do that because I said they can't. And that's very, very tough, so I try to handle it as gently and as effectively as I possibly can, but that's one of the most difficult things.
That is huge. I mean, that is your independence, and you hear that, and I'm going to bring you in, Donna, as geriatrics. You always hear, I don't want to be a burden, and that here comes, I could imagine, some of the depression. But let me ask this, if you don't have that memory, does the depression go away, or yes, no, or could possibly be, or?
I think the depression probably is there.
Okay.
And I know, we've worked with patients that have that memory loss, that 1 minute they seem very depressed because they're in the moment and are thinking, and then they go off to another place in their life, and maybe it does go away for a little bit. Or you wonder if they go to that place for comfort. My mom had dementia, and she would go to this other place, and I used to be very thankful that she did when she was younger, because it made her happier. But when she was in the moment of realizing that she had this loss, it was very difficult, and she was very tearful, and it was very depressing for her. So
we have to keep a very close eye on depression.
Right.
And a lot of times, you're right, with short-term memory loss, people do have a tendency to forget that they've forgotten things, and they forget what they just felt like 5 to 10 to 15 minutes ago. But what I like to pay very close attention to is physical signs of depression. Are they sleeping a lot more? Are they engaging in a lot less activity than they used to do? Are they speaking a lot less? And it's not because of the dementia that they've lost this ability to speak. Are they engaging with other people as much, or are they just kind of staying in their room all day and everyone's kind of taking care of them? If we can address depression type issues early on, that can be very, very effective as well. Not only because we're very concerned about our patients' emotional well-being, but the less depressed we are, we know that there's a chance that can slow some of this rapid progression of the dementia type issue. The more depressed we are, the faster the dementia is going to go. And that's what we always watch with driving, or if I'm telling someone they cannot live alone anymore, they need to move to assisted living. Those sorts of transitions can be very, very difficult.
Callers, the number is 804-915-5202. So I have seen some commercials about brain teasers and keeping the mind alert. Do they work? Is that something good to think about? Any suggestions from anybody?
They certainly don't hurt, sure. I would say. I don't think we have any evidence that medical evidence or research evidence that they help, but they certainly don't hurt. And one of the things, just like we were just saying, that those kind of things can keep somebody from being more depressed, that whole sense of loneliness. And that's one of the things we see very often with the elderly population anyway, is, they've lost their spouse, or they've lost a sibling, or whomever it may be, or their children and grandchildren have moved across the country so they don't see them. So they become isolated, and that can lead to some of their memory issues. I mean, if you stop and think about it, when you're sick or you don't feel down, when you feel down, you're not as sharp as you normally are.
Sure.
So, getting people involved in things and interacting with things and doing things like that, it's certainly, and you mentioned before physical activity too. It's certainly, we can't say it's going to help really, but we know it's not going to hurt.
Let's talk about diet a little bit. Is there something different that we should do, or that those with dementia, Alzheimer's should think about when we're talking about diet and safety?
And certainly, I know we want them to eat healthy food, and make sure that they're getting a good balance of protein. I know myself, I tend to want the sweets and the sugary things, and sometimes when I'm working with our patients, they tend to, but their taste is to more the sweets and things, but it's so important for them to have that protein and a well-balanced diet, and encourage them with that.
Okay.
I think, like I was saying earlier, I try to encourage my patients and their families to keep the patient as physically, as mentally, as socially active as possible. I think what we know is the more exercise someone gets, if there's any link between what can I do about it myself on my own, physical exercise is one of the things that the literature consistently says that is something that can be helpful. We wouldn't think about going for a walk for 20 minutes a day helping with slowing down how we're losing memory, but it really does. Diet is also very important. Individuals who have dementia might forget that they've eaten, especially if they live alone. And they may not eat as much if there's a depressive element that's going on. They may not have the energy to eat if they've lost a spouse or a family member.
Right.
Not a lot of people enjoy cooking for one, and so people tend to skip meals. And I always recommend, Ensure, taking a multivitamin, supplementing that so we make sure the brain is getting the nutrients that it needs. When we are at rest, our brain uses more energy than any other organ in our body, and we need to feed that brain, especially a brain that is damaged with a disease like Alzheimer's or any other type of dementia.
What about sleep and sundowning? But Sherry, go ahead and bring in your point.
I was just going to say that one of the things that we always tell people, and that I've heard from many doctors, is what's good for your heart as far as the exercise and the diet is good for your brain.
Sure.
Okay.
So I think the things that we've learned about to take care of our heart, watching our cholesterol, watching our sugar, watching our blood pressure, all of those things are also good for our brain.
I completely agree. I mean, the number one type of dementia that exists is a vascular type dementia, which happens when there are issues going on with blood vessels that are feeding the brain or actually inside of the brain. So cardiovascular health is automatically going to be beneficial, in my opinion. So whatever we can do to keep that patient physically healthy and heart healthy is really important.
So what about sundowning and sleep? Sleep is important, I'm sure.
And sleep is key in the hospital setting. I know I've been a nurse for 35 years, and we'd be in the units and have the lights on and noise all the time. So we're very aware of that now in the hospital setting, and so we do try to provide quiet time in the afternoons for patients so that they can rest. And also at night, make sure that we are providing a quiet environment for them, because a hospital is a very busy place, and they need their rest, and sometimes they just don't get it because we're in checking on them a lot, but we're trying to do much better job at providing that quiet time for the patients.
And what is this terminology, sundowning? I hear that quite frequently.
And I know sundowning, now that I'm working with recognizing delirium, that's kind of what we used to call it, sundowning. Now we call it delirium. That happens a lot of times in the evening. We have patients that, and with delirium, it comes and goes. So it fluctuates. So 1 minute you may be fine, but we notice that in the evenings is when they'll have that hyperactive delirium that we'll see. And usually those are the ones that get our attention because we're trying to keep them safe. They may be coming over the bed rails. They're not recognizing people. And so we as nurses, of course, will tend to them because we see this hyperactivity and we want to keep them safe. But there's also this hypoactive delirium, which makes them very, very quiet. And so they get missed a lot of times because they might be in that sundowning state, but they're very, very quiet, and they can be overlooked very easily. I say I've been a nurse for 35 years. I used to call them my good patients because you might have one that was very active and needed a lot of attention, and so you'd hear reporting and you'd think, oh great, this is a good patient, so I won't be in there much. And actually that patient needs that cognitive stimulation and that rally them up and get them going and get them out of the bed just as much as another patient needs. But many times they get overlooked. That hypoactive delirium gets overlooked.
Well, we talked about some good news in that people are aging, or the age span is growing and people are living longer, which I think is really good. And the important messages that we have talked about tonight are making sure that your heart healthy so that you can be brain healthy as well. Knowing your baseline, making sure that you're talking to your physician. So this brings up a good point too. Is dementia and Alzheimer's only in those 60 and above? And I know Sherry's going to say no. So I want to talk about that because nobody ever talks about that. And I know, Sherry, you guys have a special group for that, but that's really tough to swallow.
Yeah, unfortunately, we're seeing more and more people under the age. We normally talk about dementia or Alzheimer's starting at 65 and above. we're seeing what we call younger onset is when it starts sooner than that. And we have people as young as even in their 30s. And we do offer special programs for them. We have a support group here where the people with the disease and their caregivers come. It's our only support group that meets twice a month, and that's because they demanded to meet twice a month. And they do some social things together too, but it's very helpful for, most of them are, it's the spouses that come, they're the person with the disease and their spouse. And, very often they'll also get together in between support groups to do things together because they're not worried that my loved one might say something and everybody would be all upset, because everybody else in the group is used to that kind of thing. And we also find that our younger people, we have a gentleman out in Gloucester who was diagnosed at age 39. He's now about 49. And he feels very strongly that his job is to be an advocate. And a lot of our younger people are very verbal. They tend to be in better physical health. They don't have some of the physical problems maybe. So they see part of their job as being, as I said, advocates for the disease, and to let people know that it's not just grandma in the nursing home with the disease.
Hello, caller. Thanks for calling in. You have a question for the panel?
Yes, thank you for the show. You were talking about diet at one time, and specifically protein. I wonder if you could talk a little bit more about that. What type of protein? Is that protein from meat or protein from plant, or does it make a difference?
Thank you, caller.
I don't believe it makes a difference, the protein, whether it's plant or meat, but just an adequate amount of protein is very important.
I think, go ahead.
No, go ahead.
No, you go ahead. You'll probably say the same thing.
No, please go ahead. I was going to jump on what you were saying earlier.
I was going to say, I know a good protein diet that they always say try to get protein, at least 30 grams of protein for every meal. That's for every meal, for everybody now, good for cardiac health as well. So that's something that I would say. And then you want to make sure that your proteins, if at all possible, can outweigh some of your carbohydrates would be really a good thing to do as well. It keeps you really sharp, particularly for breakfast. Absolutely. That would be the one thing I say, don't miss that breakfast.
And that's the meal that everybody skips.
Including
myself.
I know, I hate it too, but I
their
just
coffee
get that
and no
protein
food,
in.
right?
I get that protein in. But go ahead, Dr. Khawaja.
We were talking earlier about dementia being this kind of umbrella term, and Alzheimer's kind of falling underneath that. And we were talking about the younger population that's being diagnosed with perhaps Alzheimer's type dementia, or very likely that it is. My youngest dementia patient is 19. And I do a lot of work for the military, and I'm seeing some veterans that come back from overseas that have suffered polytrauma, head injuries, from IED explosions and other combat-related head trauma and spinal cord trauma. And we are seeing an increasing rate of those patients developing dementia. What usually happens after a head injury is the person stays fairly stable, or they tend to improve, like I was talking earlier about stroke. But we are now diagnosing dementia, unfortunately, a lot in the military folks that I'm seeing with these types of polytrauma. And so we have patients in their 20s and 30s. Now, of course, that's different than Alzheimer's, but we were talking about this general trend of loss of these cognitive abilities. And the scary part is, when someone's diagnosed so young, that problem has so much longer to progress. So the propensity and the probability of it getting worse over 40 years or 50 years or 60 years of their life is really, really tough to deal with.
And go ahead.
I just want to say, one of the other things, we know that age is your biggest risk factor, but one of the other risk factors is a head injury. You know, that's why the NFL is being so careful about it. You know, they have the new procedures and everything, and why people are worried about, you know, high school and younger kids, particularly playing football and hockey and things like that, because we do know that that there tends to be more of a chance that will develop if there's been a serious head injury.
I can't tell you how many former NFL players and college football players that I've seen with concussion in this exact situation.
Well, huge. And then I want to talk about anger management with that, but there'll be another show. Hi, caller. Thanks for calling.
Very interesting show. I have a question.
Okay.
My mother is 84 years old. She's in good health, and she's still driving. I don't see any problem yet. I think it'd be kind of hard to tell her that she can't drive anymore.
Sure.
I know she would listen to the doctor, but getting her to the doctor for him to tell her
Getting
Oh,
to the
tough.
what's the
doctor.
best approach.
Yeah, that's a good point, Carla. Getting them to the doctor and being able to do that.
Okay.
So how do you do that?
Okay, so
Thank you.
I was talking about one of the most difficult aspects of my job earlier being driving, and I really appreciate the question, sir. Thank you for calling. One of the hardest things also is getting a patient to come into the office. And I've had patients come in and they are very mad at me. And I say, you haven't even met me yet. I haven't even had the opportunity to make you mad yet. And they're already mad at me. And it's really tough. And a lot of times family does say, and sometimes there's some deceit involved, just to get them in through the door. I have found that once a patient comes and I talk to them for a little bit, and I just explain who I am and what it is that we do and what we're here for, it can reduce a lot of the stress of what's going on. Because by the time the patient comes into my office, family's talking about grandma, grandpa's memory loss. Everybody's aware that something's going on. So the patient knows people are talking about me behind my back. They're going to try and take more and more away from me. And so, of course, we're all going to resist that. So the hardest thing is getting them into the office. And when it comes to driving and attention and focus and reaction time, I'm really glad to hear, sir, that your mom is doing well and in good health. That makes me very happy, and I'm encouraged by that. It's something to keep an eye on. It's something that we can test. It's something that we just, I think it's a good habit to look at for anyone over the age of 65, to be asking these types of questions. But I agree, I think it's really tough to get them in. And a lot of times what I tell my patients is, I'm here to help. I'm not here to hurt you. I'm not here to take away something from you. I'm here to help you. And in order to do that, I need to better understand how your brain works.
Well, I think you bring up another good point, because something that I've heard at some of the support groups are, we had a very difficult time getting them to you, and we feel like we're lying to them to get there. So having that rapport with a physician before, or of any nature, to get there, I think is very important to do so. But, you know, they feel really bad. So I wanted to spend some time talking about that. Any pearls for the caregiver? Like, do you just talk to the caregiver, Dr. Khawaja, before the patient? I mean, how do you, if they say, I really want them to get in here, do you have counseling or help them through that?
Yeah, we can provide all of those types of services. There are multiple times where a family member will call me, a primary care physician will call me and say, look, I really need to get this person evaluated, but I can't get them in the office. Well, if I have permission to, I'll get on the phone and call them. And I'll talk to that person on the phone if they'll talk to me. And a lot of times that can be very, very helpful. But I agree, one of the biggest struggles is with caregivers and what to do. What spouses, adult children of parents who have dementias, what do they do and how do they handle it? And that's where I think support is just such an important thing, to become a member of a support group, to take advantage of all the resources that are available here, because it's not something that you can fight alone, and it can get really, really tough. And the more support that we have, the more encouragement we have, I think the better equipped the family is to deal with what's going on.
Is anger always there? I hear anger a lot.
I hear anger a lot too, and some of it has to do with, as our frontal lobes change, as dementias progress, and some of the other, with frontotemporal dementia, for example, with dementia of the Lewy bodies, for example, anger management issues and impulse control problems can really be an issue. The question again becomes, how much of this is depression and psychological? We're reacting to the fact that all these people are talking about us now, and we're aware that we have been given a diagnosis, and there is that natural adjustment anger reaction to that. Nobody wants to be told what to do. Nobody wants their children, parents are used to being parents. Now all of a sudden their children are telling their parents what they can and can't do. And that's where coming in and talking to somebody like me, or taking advantage of some of these resources, can be really helpful, because I can have that conversation with that person. We can talk about what that's like. My job is to help and to advocate and assist not only the patient, but also the family. And I just say, please take advantage of those resources.
And Donna, Sherry, both of you said, and I wanted to bring this in, how you talk to the person, and you kind of mentioned to that. Not talking over them, they're still there. So I know that's a very important part of the program. for help, and also for niche. We didn't talk about that at all, but if you want to bring that in, Donna, a little bit and just
yes, absolutely.
explain that program.
Talking to our patients as they are adults. That's one of the things, I think over the years that we've seen that we speak with them like they're children, and they're not. They're adults, and so you need to be very proper in how you address them and how you speak to them. That elder speak, we want to make sure that we're talking to them correctly. Yeah, we have a program called the Niche Program. It's Nurses Improving the Care of Health System Elders, and it's a national nurse-led program that actually has learning modules on it that our nurses can get on and learn how to give excellent care to older adults. We have right now 157 nurses that have gone through the program, and we also have 13 of our patient care techs that have gone through the educational modules to learn how to give that excellent care. And of our 157, we call them geriatric RNs. Once they've completed the learning, they can become certified through ANCC by taking a certification test. So of our 157 nurses, we have 24 that are certified geriatric RNs. The program also will allow interdisciplinary team members, physical therapists, care managers to go through the program as well. So we have 54 of our interdisciplinary care team healthcare workers that have also gone through the program. And it just helps us to be a better team in caring for the older adult.
Sherry, let's talk about a little bit more of your programs. I know the support groups that you have. And actually at Mary's, St. Mary's, we do have an educational series that we're doing with Alzheimer's. The next class, I think, is February 28th, and we certainly will have that on our website. They don't have to wait till February 28th for that. I know that you have, if you want to give your website and the number that people can certainly have, that would be great.
And I can tell you, we're coming up on a time of year when we get a lot of calls because families spend time together over the holidays.
Yes, we need
The
to
week
talk
after
about that.
Thanksgiving and the first week of the year, our helpline calls go way up because people have spent time and they're concerned. And they want to know, what do I do? How do I get a diagnosis? What information? What questions should I ask? And we have information on that. Not only do we have lists of physicians, but we also have lists of these are the kind of things you should be prepared to answer from your physician. These are the kind of questions you should be prepared to ask of the physician when you go in. So our helpline, our 800 number is 800-272-3900, and that's the one that's 24/7, 365 days a year. There's also a lot of information on alz.org, which is our national website, and then from there, no matter where you are, you can put in your zip code and it will bring up the information on the chapter, the chapter website, and that has lists of our support groups, our upcoming programs. One of our programs that we do quite a bit is Know the 10 Signs, so that people know what should I be looking for in my loved one. And we also have the next program that we're doing with you all, the February program, is on communication. You know, Donna was talking about things that they teach their nurses and things to do. Well, we try to teach family members of how do you communicate, what are some of the things that maybe are triggering some of the issues, some of the behaviors you're seeing, and what are some things that maybe you can do to avoid some of those things. And, you know, we talked earlier about sundowning, and, you know, if you know that your loved one has a problem as it begins to get dark, then plan an activity with him at that point so that he's involved in something, he or she is involved in something with you, rather than sitting there and getting upset because, you know, the lights are coming on and things like that. So those are the kinds of tips that we can give to caregivers.
So I really like you said the point about triggers. And again, this is going back to knowing that baseline, knowing that person very well. I mean, I think this is where family really needs to be strong with family. But with the caregivers, you said the holidays are coming up. That can be that's a stressful time for everyone.
It causes a lot of depression.
So it causes a lot of depression, a lot of angst. You may feel, and not only the holidays, but we're in the holidays, And Richmond's not so bad, but think about the holidays where you can't get out of the house because of the weather. So I don't know, again, if you all we have a few more minutes left, if there are other things that you want to bring up. I can't get off the younger population too. Again, I think the audience needs to understand that when we're talking about Alzheimer's, it does not have to be somebody 65 and older. We talked about dementia, and knowing that there are some core components, and what we're looking for is a progression in memory and being able to communicate and some other components, and it's progressing. It's not getting better. And so if you see your younger patients doing that, or your younger family members, don't forget that they may need to see the doc. So I'm going to give you, we have about 40 seconds each. I'll start with you, Sherry, on anything you want to bring
Well,
on.
I think the main thing is, particularly as we've been talking about the holidays, is that if you notice signs, unfortunately, lots of times people want to deny it because they don't want to admit that mom's having a problem or that dad's having a problem or whoever. But it's important because, as the doctor was saying earlier, that the sooner you get people on those medications, the more apt they are to be helpful to them. Later stage, it may be too late to see much success from them. So if you've got questions, go to your doctor, call us, and get information that we can give to them on, as they say, what are the signs, who can you call, what are the questions you should ask.
Okay, Donna?
Absolutely, and I would say, caregiving is a huge job. So during the holiday season, plan as caregivers to give yourself some time to rest and relax, because it's very important, because you're doing a monumental job in caring for our older adults. So please take care of yourself, because it's so very important. I've been a caregiver for my mom and my father-in-law, and it's a huge job, and so you've got to make sure you take care of yourself.
Dr. Khawaja?
I'd say a couple of different things.
Okay.
I always talk a lot, I'm sorry. I think for me, again, early detection is really, really key. And the type of testing that we do, it doesn't hurt. It's 3 hours out of your life to come in. And one of my biggest regrets is that I oftentimes have to tell patients and families that I do think it's too late, that I think we waited. When I ask, how long have you noticed these symptoms been going on for? And they say, oh, this has been going on for 5, 7, 8 years. And now all of a sudden some major mistakes are happening, and that's when they come in to see me. I really would like it when I get to tell patients there's nothing wrong. And I can do that if you come in early enough, or that the best news is that there's nothing wrong, but the second best news is I think we've found an issue, but I think that we've caught it early. Here are some things that I think we need to do, because we need to prepare. And I always tell my patients that we need to hope for the best, and we're going to do whatever we can to help. If we can't fix memory, or we can't address memory, maybe we can help with attention, concentration, and focus. Maybe we can help improve depression. Maybe we can help improve speech and language. There are things that we can improve and work on. And the other thing too for families is that we need to prepare early in case things do progress, because we know it will likely progress. So we need to have our wills and power of attorneys and things like that done.
All right, well, thank you. This was a very informative show. We certainly will have this up on our website, because we know that people will want to see this to help you to get through the holidays. Next week, we'll be talking about stroke, how you can beat it, how you can treat it, and we will have some rehab specialists as well. I'd like to thank the panel for being here tonight. As again, I said, it was very informative, and all of their information will be on the Bon Secours website. If you go to Bon Secours and look under Neuroscience, you will see that information. Thank you for being with us for this hour, and again, hope you have a fabulous week, and stay tuned and pay attention to your neuro signs and symptoms.